Whenever you're ready.
Wonderful. Okay, good evening, everyone, and maybe good afternoon, and some of you maybe very early morning. Thanks for joining us today. Today, this webinar is on climate change and the heart, cardiovascular research, clinical and sustainable sustainability considerations. So this is a work joined by, organized by the Yale Center on Climate Change and Health. I'm the faculty director at the Yale Center on Climate Change and Health. And the whole idea is try to bring in our dear colleagues from School of Medicine, but also here at Yale School of Public Health, for us environmental epidemiologists working together to see the evidence-based exploration of all the different climate-related hazards, how they can affect cardiovascular health, and explain the strategy and opportunities to protect the patients and enhance resilience in terms of the climate change health impact, and also identify how cardiovascular care is influencing climate change and opportunities for healthcare sustainability. So joining me today, I'm very pleased to have our colleagues. I will follow on the order of the presentation. Dr. Yuan Lu, who is assistant professor of medicine in cardiovascular medicine, and Dr. Lawi Balumkanda, associate professor of medicine, also from cardiovascular medicine, and Dr. Andrew Chan, assistant professor of medicine from the cardiovascular medicine as well, and Dr. Erica Sposs, associate professor of cardiology and director of the preventive cardiovascular health program. And unfortunately, Dr. Jody Sherman, who's associate professor of anesthesiology, couldn't join us today. So we will begin today's presentation basically with the three different competencies. The first one will be introduced by me and later Dr. Yuan Lu on how we understand climate change is impacting our health, particularly on the cardiovascular side. So with that, I will get started for the first one. So when we talk about climate change, if you look at the record, here shows the global average temperature since the from the very early decades to most recently. And what we can see is actually you see now the pattern that after 1970s, actually we see the global average temperature climbs dramatically. And as a matter of fact, in the past decade also, we actually see the global average temperature become one of the warmest on record. Um, and if you look at the past 3 years, that is actually the three warmest year on record, right? We have 2024. That was the first year that global average temperature surpassed the 1.5 degrees Celsius. And 2025 was only marginally cooler than 2023. So both 2023 and 2025 were kind of similar among the warmest year on record. So what does this mean? With a warming climate, we not only have more heat, more extreme heat, these heat days become more frequent, more intense. Sometimes heat waves also occur more early, like what we have observed this year in the West Coast. But also when the atmosphere holds, getting warmer, it can host more moisture. So in some places, the more moisture means you will have more frequent and more intense rainfall event. However, in other places, that could also mean you have less rainfall, so it could lead to more drought events. And as we've seen, in the past few years, Wi-Fi events has become more frequent, right? We always seen that the Wi-Fi activity is not just the West Coast problem. As a matter of fact, last month we see that in Georgia the Wi-Fi is reaching across many places. In addition, we're also facing acidified ocean. That is something that we will not be touching today. But all these extreme events we have seen, has indeed becoming more frequent and more intense. So the question is, what does this mean for public health? Well, climate change can impact our health directly through these extreme weather events, but also indirectly through worsening our water quality, impacting our air quality, goes together with land use change and ecological system change. And all these impacts can intertwine with our social dynamics, like our public health infrastructure change or population aging. They can impact not just our physical health, but also our mental health. So consequently, actually, Lancet has a commission on health and climate change made the expert judgment that climate change is the biggest global health threat in the 21st century. And many, based on evidence, believe that this is still true, despite that we already have a COVID-19 pandemic. So the first thing I think what we want to do here is, uh, you know, getting some basics about climate change. So what do we mean when we talk about climate change? Well, many of these lecture we will base the materials on the Intergovernmental Panel on Climate Change (IPCC) reports, the most recent reports. What it shows is basically here on this figure, the global average temperature from pre-industrial level all the way until today, but also looking into the future by 2100 all the different possible pathways we human as a whole race are choosing. Are we going to have more what we call greenhouse gas emission, or are we going to choose much less greenhouse gas emission? And as you can see, no matter which pathway we're choosing, unfortunately, the global average temperature we're going to increase. What matters is that if we choose a very high emission scenario, we'll have much larger warming compared to if we choose a very low emission scenario, that will be relatively less warm. So one item that people always talk about is the greenhouse gas effect. Well, I want to make clear that the greenhouse gas effect itself is not necessarily a totally bad thing, because essentially, what does the greenhouse gas do? It is, if you think about it, it is like a blanket. So it's a blanket on the land surface, and because of it, so the radiations can be reflected back, so it kind of can keep the Earth warm. And what are in the greenhouse gases? These include actually water vapor has a large potential for global warming, and carbon dioxide, as well as methane and nitrogen oxide. And because of the greenhouse gas, it is estimated that if we remove the whole greenhouse gas, the land surface temperature will actually be negative 18 degrees Celsius, which will become totally inhabitable for our human race. So in a way, greenhouse gas per se is not like entirely a bad thing. The problem is that our blanket is getting too thick. So we get it too hot to live. Okay, as we can already see from the observation data from the past decades, we see the warming trend. But if you look at much longer, climate scientists being able to reconstruct our global average temperature using not just ground monitor stations, but observations from, for example, ice core or from the tree rings, so they can reconstruct the global average temperature back, to thousands of years ago. And on the left figure, you can see about 2,000 years of history, observed temperature. You can see that it looks like what we call a hockey stick. It's only in the very recent years. As a matter of fact, right after the Industrial Revolution, we do see the global average temperature has a very quick jump. And this warming is truly unprecedented in more than 2,000 years, because we technically are in a period that leading to more kind of cooling rather than warming. And because of the Industrial Revolution, because the greenhouse gas emission that was unprecedented emitted to the air, we have a much warmer climate. So the question always like, okay, we know the climate is warming based on the observation data, but how do we know humans are responsible? Well, one of the things that climate scientists can do is build a very sophisticated numerical model based on physics and chemistry. These are what we call global climate models. And because you have a model, so climate scientists can do some experiments. Essentially, what they do is that, okay, they could remove all the human-induced influences, all the greenhouse gas emission from human activities that can take that out, and you can run the model again to see what the global average temperature would be. That actually, on the right panel, you will see uh, the lower panel showing the simulated, if we only consider the natural emissions, you can see there's a big difference between what accurate is, right? So we don't see such a larger warming extent. It's only when the scientists adding back the human inference that we can see the model shows almost reproduce the whole observed temperature. So that difference, when you add human inference versus not, so that delta actually is the signal showing us the human inference preprint, a footprint. So that tells us the humans actually, the emission from human, generated the greenhouse gas emission. These are mostly responsible for the warming that we have seen in the observation data in the past decades. And before we move on, I think I also want to, level the playground to, some of the key items to clarify the definition. So when we talk about climate change, one thing people, many get confused, and especially climate deniers try to use the evidence, is a confusion between weather and climate, right? So we always hear that, okay, you have a huge, very cold winter, then what about all the climate warming argument? Well, that is because there's a big definition difference between what we call weather and what we call climate. So think about it this way. Weather is basically tells you what you want to wear today. But climate actually tells you what types of clothes you want to have in your closet. So you see the difference is actually climate is what you expect, but weather is what you get. So that difference is speaking of the time scale. So weather is the atmospheric condition usually from minutes to weeks. But climate is really a long-term average from seasons to even decades. So this actually speaks of why we talk about the 1.5 or 2 degrees Celsius warming as the Paris Agreement target is so important. So you may wonder, well, in our everyday life, the daily average temperature can range more than 10 degrees Celsius, or sometimes in the Fahrenheit scale, for example, in New Haven, we often have more than 20 degree Fahrenheit changes from daily maximum versus daily minimum. So why does 1 degree Celsius change such a big deal? Well, this is because the 1 degree we're talking about is a global average temperature. And because it's global average, we take consideration both the land temperature and the ocean surface temperature. So the ocean with its mass depths and mass, it actually gets warmed much slower than the land. In a way, we actually, when you see an average temperature, the land is actually warm much faster than the ocean. And that's why ocean always has a huge lag, in terms of getting warmer. And when you even just looking at the land, in the land, the average temperature, this is the all year round temperature we're talking about. And if you zoom in to the summer temperature, here in the right panel shows the temperature distribution in the northern hemisphere during the summer. In 2005 to 2015, this decade temperature, summer temperature, compared with a historical baseline period, from a 30-year period from 1951 to 1980. What you can see clearly is that although the average temperature does not change that much, there are way more days, hot days, or extremely hot days. So you see the extremely hot days distribution is dramatically exceeding what we have observed in the past. So that's why even though the global average, annual average 1 degree Celsius looks small, but it actually means a lot when you're looking at how many days, on the land during the summer we actually experience, especially in terms of extreme heat days. That is why we have more frequent and more intense extreme heat days. The second key item I want to clarify is since we are talking about the climate as a long-term statistic, right? So a change in the climate or climate change needs to be, by definition, a statistically significant variation in the either if you look at long-term average mean or other measures to have a larger change or typically a much longer period. It can usually from decades or even longer. So here below the panel shows the global average surface temperature change relative to the pre-industrial level from 1850 to 1900. And on the different curve shows the different what we call shared social economic pathways. It's essentially the plausible kind of emission pathway into the future, whether it's going from the SSP 1.9 very low emission to SSP 5 8.5 very high emission. And as you can see, by the end of this century, the global average temperature model shows us that the very high emission scenario SSP 5 8.5 would actually lead to more than 4 degrees Celsius warming. Almost double the Paris Agreement of the 2 degrees Celsius target. Luckily, thanks to all the global climate policy, technology, innovation, clean energy adoption, we're not on the SSP 5 8.5 anymore. It used to be called the business net zero, but now we are more or less somewhere between the SSP 370 and SSP 4.5. But still, you can see we are on the trajectory of a 3 degrees Celsius warming world. And the only way that we can keep the global average temperature below 2 degrees Celsius is really have a low emission scenario, either SSP 1.9 or SSP 2.6. The third key term when it comes to public health, I want to touch on the vulnerability definition. So vulnerability in different disciplines can mean different things. So here in the health effects of climate change, we typically refer to the U.S. Impacts of Climate Change on Human Health report in 2016, which defines vulnerability as 3 key components: how much people are exposed to the climate-related hazards, how sensitive people are. For example, even at the same exposure level, people are affected differently. And then even with the same exposure level for the same population, people may different communities, different population, different income level, for example, may have different capacity to adapt to these kind of climate hazards. So exposure, sensitivity, and adaptive capacity. These are 3 components that jointly determine the vulnerability to climate change. And we will touch this more and more later, but generally, in terms of health effect of climate change, we see older adults, children, pregnant women, with communities of color, and the low-income communities, they either have high exposure, more sensitive, or have low adaptive capacity. The final key item I want to introduce here is the way to kind of address climate change is depending on, if we are going to tackle the root cause by reducing the emission, by using more green, energy, or using more public transportation, using electricity. These can measures called mitigation. And the other part is, how to reduce population's vulnerability to climate change, so that even though we have the warming climate, but we will have a less health impact. So the adaptation measures these are actions to reduce the vulnerability. And the second part, what we're going to touch on is the cardiovascular health effects of climate patterns. I will quickly go through the evidence on temperature, and then we'll pass on to my colleague Yuan Lu. So basically, when we look at ambient temperature, we know too hot or too cold is bad for health. Actually, epidemiological evidence shows this is kind of U-shaped relationship between temperature and health risks. But what it tells us is that also, if you look at this curve, heat does not need to reach the 99th percentile to become deadly. At 85 or 90th percentile, we still have significant mortality risks. And because we actually expose more days during these moderate heat days, that actually brings a large substantial health risks, a burden. We can dive into why does heat can kill people. We know there's heat stroke, but actually the large like a burden from the heat-related health impacts is actually the non-communicable diseases that are not directly coded in our ICD codes. So to give you two examples, we using a nationwide private health insurance database, we found that heat can lead to substantial increased heart attacks events and also stroke events. And consequently, when we estimate nationwide in the US, there are about more than every year for the past 20 years, every year can be more than 3,000 deaths due to heat-related exposure. And what we observe here is actually heat-related annual deaths in the US has actually increased by more than 50% over the past 2 decades. So indeed, we are seeing a much larger and increasing heat-related risks. And with a warming climate, what's more challenging is that we are not living in a world that only climate is changing. One important social economic change is population aging. So here shows the temperature projection in 800 locations in 50 countries and regions. And when we look at these regions, actually, we see that older adults, for example, people more than 74 years old, they're more vulnerable to both heat and cold exposure. So the consequence is that the whole human susceptibility to temperature is becoming much larger. So consequently, when we look into the future, we'll see increases in cold-related mortality and a much larger increase in heat-related mortality. So when combined, we'll see overall future temperature-related mortality to be increased dramatically. And with that, I will pass on to my colleague Yuan Lu to introduce the health effects of extreme weather events.
Thank you, Kai. Earlier, Kai discussed climate change and rising temperature. So now I want to shift the focus to another increasing important issue, extreme weather event and their cardiovascular health impact. Here you can see several recent examples. Droughts in Poyang Lake in China, flooding in Texas, and the recent wildfire in Los Angeles. These events are no longer isolated environmental disasters. They are becoming more frequent, more intense, and more prolonged under climate change. And importantly, they lead to cardiovascular events. Next slide, please. Let's start with wildfire smoke. Historically, wildfire smoke have mainly been discussed in the context of respiratory disease. But over the last several years, evidence has increasingly shown important cardiovascular consequences as well. So this study demonstrated that wildfire smoke exposure was associated with increased stroke risks among older adults using Medicare data. Several biological mechanisms may contribute, including systematic inflammation, oxidative stress, endothelial dysfunction, and increased thrombogenicity. Another important point here I want to point out is wildfire smoke can travel very long distances. So even populations far away from active fire may still experience substantial exposure. Next slide. These slides summarize one of our recent studies published in JACC. We analyzed approximately 65 million Medicare beneficiaries to examine long-term exposure to wildfire smoke PM2.5 and cardiovascular hospitalizations. There are several key findings. First, wildfire smoke is not only an acute exposure problem. Long-term cumulative exposure also appears to increase cardiovascular risk. Second, the association varies across cardiovascular conditions. Here we show different outcomes here, with the strongest relationship observed for heart failure. And third, older adults with lower socioeconomic status appear to be particularly vulnerable. This highlights that climate change is not only an environmental issue, but also an health equity issue. Next slide. This is another study further quantified the mortality burden attributable to long-term wildfire smoke PM 2.5 exposure in the United States. One important concept here is that wildfire smoke rarely occur in isolation. It often co-occur with extreme heat. So in real world, populations are exposed to multiple climate hazards simultaneously, and this combined exposure may have amplified health impact. So this is another slide highlight very important emerging area of climate health research, compound climate exposure. This study showed that co-occurring extreme heat increased mortality effects of smoke PM 2.5 exposure. In other words, when heat wave and wildfire smoke happen together, the health impact may be substantially worse. This is important because future climate-related exposure are unlikely to occur once at a time. Heat, air pollution, wildfire, drought, and floodings, they are often interconnected. As a result, future research and public health strategy increasingly need to move beyond just study a single exposure in isolation. Next slide. Flooding is another major but often underappreciated cardiovascular risk factor. When we think about floods, we often think about trauma, injuries, but floods also produce many indirect health effects. For example, it could contribute to cardiovascular mortality through disruption of healthcare access, interruption of medication supply, psychosocial stress, contamination of water systems, and displacement of communities. So all these factors can contribute to increased cardiovascular risk. This study in Nature Water demonstrated an important association between flooding and cause-specific mortality. Next slide. This is from another recent study estimating flood attributable mortality across the United States. Between 2001 and 2020, more than 22,000 all-cause mortality could be attributable to flood in the US. This is associated with like almost 10,000 deaths annually in the US. Importantly, these burdens are not evenly distributed. We can see from this figure, certain regions, particularly areas such as like Texas, experience substantial higher impact. Again, it emphasized that climate change again affects population unevenly. It could be geographically very different, socially and medically very different as well. Next slide. This is kind of a busy slide, but it summarizes how we study health impact of climate change. In general, we combine several key components together. We need to define the study population. We start with the baseline rate of health outcome, and then we add on expected change in exposure, and we also multiply by the exposure response function. All this allow us to estimate the future health impact. However, there are still many important challenges. For example, there are limited long-term data, so maybe only allow us to estimate climate-sensitive outcome. There's a lack of quality data, and there's limitation in the exposure and response function. So in the end, it highlights future major gaps in research. We need to study mortality outcome, cardiovascular outcome. We need to look at the long-term cardiovascular health effects, not just the short term. And we need to better understand adaptation effects over time. Next slide. So just to briefly summarize, this is a slide that I think Kai showed at the beginning. Climate change affects cardiovascular health through multiple pathways. It included direct pathway through this extreme event, but also indirect effect through water quality, air quality, change in land use, and broader ecological change and social dynamics. One important point is this impact disproportionately affect vulnerable population, including older adult, lower income communities, and patients with existing cardiovascular disease. So I think climate change is no longer just an environmental issue. It is increasingly becoming a core issue in cardiovascular medicine, in population health, in health system planning. So in the future, we need to think about how we can combine different data sources like cohort registry, survey, hospital record, and vital statistics, combine all these together to better understand the impact of climate change and how we can mediate the harmful impact. Next slide. And at the last, I just want to acknowledge amazing team at the Yale Center for Climate Change and Health, which we have collaborated a lot, and all the collaborators for this excellent research. Thank you.
Wonderful. Thank you. I think I'll then pass to the second competency, led by Lawi. Lawi, I think you're muted.
Yeah, Kai. Yeah, thank you. I just wanted to share my slides. That was an excellent presentation by Drs. Chen and Liu. Thank you for introducing us to the concepts of climate change and then walking us through all the ill effects of climate change as it pertains to cardiovascular health. Now that you've set up the stage, let us talk about how can we address this, this problem. It seems like all doom and gloom, but my colleagues, Dr. Chang and Dr. Spatz, will try to address some of these issues and what we as physicians can do to help protect our patients. At an individual level, I will talk about that, and then Dr. Chang will address the public health interventions, and Dr. Spatz will take on the communications aspect of it and see how we can communicate and offer solutions through that. One of the big things, as Dr. Chen and Dr. Liu have suggested, is air pollution. I will touch upon air pollution, heat, and extreme weather events, and see how patient-level interventions can be offered. And starting with air pollution, this can be a gargantuan task.
So,
when you think
Lawi,
about,
I'm not sure I'm seeing you share the screen. Has anyone can see that? It says you paused screen sharing.
Sorry. How about now?
Yeah, works. Thank
All
you.
right. Thank you. Thank you, Kai. Okay. Air pollution is a task that needs to be addressed on multiple levels. Kai mentioned the IPCC, the IPCC, WHO, the UN have all laid out position statements to help us shift from fossil fuel reliance to renewable energy, and that needs to come from a higher level. At a societal level, we can work on creating towns and cities that are more friendly to bike, have more bike paths, have green spaces that will allow us to reduce reliance on fossil fuel. And there's a number of studies that shows that towns with green spaces and bike paths have lower incidence of cardiovascular events and mortality. And then at the healthcare systems level and systems planning, we do what we're doing right now. Talk about the problem, come up with solutions, educate ourselves, educate the next generation, come up with curriculum that incorporates discussions on climate change and impact on health. And on an individual level, we use both mitigation and adaptation strategies. The mitigation strategies are similar to what we discussed earlier, which would be to reduce reliance on fossil fuels. And then coming to the adaptation strategies, specifically as it pertains to cardiovascular health, there are a few things that have been looked at. The pathophysiological mechanism of air pollution's impact on cardiovascular health is through the fundamental pathophysiological mechanism is of oxidative stress. So antioxidants such as vitamin C, vitamin E have been tested. Statins have been tested as well. And they've been shown to reduce surrogate markers like CRP. However, outcomes such as mortality, myocardial infarction, and heart failure, these metrics have not been looked at yet. Larger studies are needed to see the impact of these medications and pharmacological interventions on these outcomes. Now, reducing exposure seems like a common sense intervention. If the patients are trying to exercise, trying to stay away from at least 400 meters from a highway with high traffic and air pollution from traffic-related air pollution can be a good intervention. Avoiding travel during peak traffic is another intervention. Interestingly, just closing the doors and windows and staying indoors during high air pollution, when the air pollution levels are high, reduces both this biomarkers such as CRP, fibrinogen levels, and also improves heart rate variability. Again, all surrogate markers of cardiovascular health. And then individual protection measures such as wearing a mask, using both car filters and portable air filters at home and at work are all other interventions that can be used to reduce exposure. This is a very nice study that was recently published that looked at patients with elevated blood pressure levels, and then they randomized patients to HEPA filters versus sham, and then they did a washout and crossover design. And they found with just 1 month of using of HEPA filters, a significant decrease, statistically significant decrease in the systolic blood pressure in these patients. So again, filters would be an intervention in certain patients. The EPA puts out this levels of air pollution on a daily basis and classifies it in this color-coded metric, and it gives data on various air pollution, including ozone levels, particulate matter, and carbon monoxide. However, routinely using this on all people, general public, would not yield a significant benefit in reduction in cardiovascular outcomes. In this study, they found that classifying the patients according to their cardiovascular risk and to low, intermediate, and high risk would benefit us by lowering the number needed to treat with interventions that are suggested when the air pollution levels are very high. And in this paper, Rajagopalan and his colleagues have done a very good job in trying to risk stratify our patients, and as opposed to offering a one-size-fits-all solution, they suggest looking at air pollution levels, the particulate matter levels, and then classify them into low, high, and hazardous levels. And once you've classified the ambient exposure, then you classify the risk of the individual patient. Again, you classify the risk of the patient based on their established risks, such as risk if they have prior history of heart failure, or they've had a heart attack or COPD, or if their baseline ASCVD risk, 10-year risk is more than 20%, they've had CKD, or special circumstances like pregnancy, elderly patients, and also heart transplant patients. These are all identified as high-risk patients. And then you further classify them based on that, and then use the exposure risk to intervene on these patients. And you can ask, if the patient is at a high risk, then you can ask them to wear a mask, stay indoors, or use HEPA filters to reduce the exposure. Now, switching gears to what interventions can be done with suboptimal temperatures, especially increasing heat. This is an interesting slide. And when we talk about the Chicago heat wave, the general thinking is that the heat caused most of the mortality. However, when you look at this, you see that cardiovascular mortality was significant in these patients. And hence, and this is another trial that was done in a Chinese population, you see the significant increase in more MI-related mortality with increasing temperature. And as Dr. Liu suggested earlier, it's a combined effect with increasing particulate matter. The effect is amplified further. So combined exposure is significant. Now, the impact of heat waves and the heat risk can be obtained on a regular basis, on a daily basis. The CDC puts out, you can put the zip code in, and it gives you the risk of heat-related health risk. And what do we do about this? With that information, we can then counsel our patients to stay away and stay indoors when you have a heat dome effect or there is rising temperature or a heat wave. And as you can see, even in the Northeast, over the past few decades, we've seen almost doubling of the air conditioners in homes throughout the country. And specifically in the Northeast, we've seen a doubling of the patients using or general population using air conditioning. This is also associated with rising cooling cost. However, not everyone, and especially those in the low income households, about a fifth of them do not have access to air conditioning. And this is compounded by the fact that some of the assistance programs that we have, this, for instance, the CT Energy Assistant Program that helps pay the bills for low-income households, does not cover cooling cost. It only covers the heating cost. So it only kicks in during the winter months, and during the summer months, these people are exposed to a high heat without access to air conditioning. So these are all things that we as physicians have to be cognizant about while counseling our patients. Now, switching gears to medications, a lot of the medicines that we use impacts body's natural response to environmental stressors. So there are medications that we routinely use in our cardiovascular patients, which can impair the central thermoregulation, so they cannot have normal cooling mechanisms in place. It impairs sweating. There's some of the medications that impair dilation of the blood vessels and hence helps the body cool. They can also be medications that we prescribe that causes dehydration. And during the last 2 heat waves that we've had in Connecticut, we've had a lot of patients with heart failure who've been very compliant with taking their diuretics come in with dehydration and renal failure. So we have to be cognizant as physicians in communicating these extreme weather events to our patients, and then counsel them on how to modify their medications. There is also data that some of these medications are less effective with increasing heat and increasing humidity. The stability of the medications, medications such as antibiotics, some of the immunosuppression medications are not stable in higher temperatures. In addition, during extreme weather events, we've seen it during Hurricane Helene, where there was a significant disruption in supply chain. We all remember the disruption to IV fluids when Baxter's factory closed down in North Carolina, and we had an extended period where we did not have access to IV fluids. And on the heels of Hurricane Helene came Hurricane Milton, which caused a significant disruption to ports and trains and again, impaired the supply chain for a lot of these medical supply chain issues. In addition, a number of these medical equipment run on electricity. Loss of electricity during extreme weather events significantly impairs our patients' well-being and also can put them at risk of mortality. Heart pumps need continuous electricity, the LVAD pumps. Patients depend on home dialysis machines and CPAP machines. These all need continuous supply of electricity, which can be disrupted during these events. So in summary, on a patient level, a detailed history of exposure. Where does the patient live? How close are they to a highway? Where do they work? What's their commute like? That helps us understand their exposure risk. And then a detailed history of patient risk to help risk stratify them. And then counseling them on medication use and helping them plan during extreme weather events would help mitigate some of these environmental risks that our patients will continue to face with the warming climate. I will pass this on to my colleague, Dr. Chang, I'm sorry. Dr. Chang is next.
Lavi, can I just prompt you to through my slides as well, or?
Sure, yeah.
Okay, great.
Let me. Alex, can you put up the master slide deck, please?
Yes, 1 second. If anybody else has it ready to go.
I can do it too. I just figured it would save us a little time, but let me see. I'm going to share then. All right, let's see. All right, can everyone see these slides okay? Excellent. All right. So as Dr. Belcondo mentioned, my name is Andy Cheng. I'm one of the in cardiovascular medicine here and also a faculty affiliate with the Yale Center for Climate Change and Health. So I'm going to be moving on to part 2, which is the public health interventions to impact the cardiovascular effects of some of our climate change recommendations. So as mentioned before, I don't have any disclosures to report. I'm going to focus on extreme heat, largely because of time constraints and also because a lot of you already talking about air pollution. And so regarding extreme, there's sort of the upstream the most visible of them is the heat health warning system. So I'll spend most of the time talking about that. And the goal of these upstream health warning systems is basically to motivate these downstream interventions. So some of them, Dr. Belcondo already went over, these individual level behavioral changes, such as air conditioning, avoiding outdoor or strenuous activities, and passive cooling techniques. So I won't go into that. But also a public health intervention is that of cooling centers, which are often offered by me. I don't think I'll have enough time to talk about, but if for some reason I'm magically running ahead of schedule, we'll briefly discuss those. So we will focus this section mostly on these heat health warning systems. So heat health warning systems come in a variety of different shapes and sizes depending on the location. So I'm going to focus on the United States. And on the national level, the U.S. National Weather Service, or NWS, has a national level heat warning system, and it provides these for the 122 weather reporting regions that are scattered across the United States and basically divide up the U.S. as a map. And the NWS will typically communicate when they believe that one of these heat events is headed with local authorities. And based on the heat index, the temperature and relative humidity, they decide one of several warnings. Now, these are the national warnings. There's a whole host of local heat warning systems as well, too. And one that we're going to talk about is the Philadelphia Hot Weather Heat Watch and Warning System, or the PWWS, which was put in place by the Philadelphia Department of Public Health in the late 90s and early 2000s. And it uses local meteorological and weather factors as well. And we call this the synoptic logic procedure. So members of the audience may have seen some of these in their jurisdictions and their areas where they're living as well, on the phone or on television or radio. And they come in three different flavors. These, again, are the National Weather Service related alerts. So first, we've got the heat watches. And an extreme heat watch is usually issued in the 72 to 24 hour prior to the event range. And the idea is that a heat event may be coming. So it's summarized here, be prepared. And then you have an extreme heat warning. And the heat warnings are usually released in the 12 hours to 24 hours time frame before the event. And so typically the warning is actually warning individuals that the dangerous heat event is happening or it's imminent. And so the idea here is that one should be those already discussed by Dr. Delacosta. And then finally, there's this concept called the heat advisory, which is issued for dangerous heat conditions, but not necessarily those that reach the warning criteria. And so these are sort of the three flavors of the National Weather Service alerts that folks may have heard. And how do they work? Well, we'll discuss a couple examples. And the first is that of the Philadelphia heat weather system that we introduced a moment ago. And this is a local heat health warning system. And Christy Ebby, who's now at the University of Washington, published this analysis back in 2004 in the Bulletin of the American Meteorological Society, where she and her group basically modeled standardized mortality in the city of Philadelphia during these years in 95 through 98. And analyze the effect of that heat warning on overall mortality. And what they estimated was that between 1995 and 1998, when this was in effect, that perhaps about 117 mortalities were averted. Now, a similar analysis, which was done using analogous methodology by Chow and colleagues, looked at Hong Kong and specifically looked at cardiovascular disease mortality, which is what we're interested in today on this webinar. And what Chow and colleagues found was that when they restricted the analysis just to adults over the age of 65 and looked at ischemic heart disease and stroke-related mortality, they concluded that in between the years of 1997 and 2005, that had a heat health warning system, there is one that is active in Hong Kong, but that had it been in use on days that it had not, then up to 727, roughly, ischemic deaths, and about 507 stroke deaths could have been prevented. Now, what if we looked at a little bit of a wider side of these more municipal examples? Well, looking in Germany, did a differences, sort of a pooled meta differences analysis looking at large cities in Germany. And what they found was that actually that there wasn't really a reduction in overall mortality. What they concluded, though, was that there was high regional variation. So different cities had different effects. Some had particular effects. And in addition, they found that when they controlled in their analysis for geographic features such as recreational area per person, total population, and population density, that there turned out that there was a predictor. Now, in another analysis, Dr. Selke He and Dr. Michelle Bell, who's also a faculty member in the Yale Center for Climate Change and Health, found that in the 8 largest cities, basically corresponded to provincial and unfortunately, the heat wave warning system that's in effect there did not have an effect on overall or cardiovascular mortality. In subgroup analysis, they did find that cardiovascular mortality was reduced in older adults who were widowed, those aged 75 years and older, and in younger populations, but those who had no formal education. So why the discrepancy between some of these small and municipal studies and larger studies? Well, part of it was implied by some of the comments from the papers themselves. And first, it's that the health, the risk of health injury from heat may be concentrated again in the most vulnerable. So again, older adults, those with low socioeconomic status, or people with recent. So looking more broadly at the population, perhaps the impacts might be washed out a little bit. And then perhaps a more salient comment is that the heat warnings themselves may not be enough to avert the mortality that we're seeing. What I mean by that is this. So the Philadelphia heat warning system, part of it was devised by Dr. Yale, and they actually cover, and I think this is good reading for all of us with our infinite free time for literature
Andy,
review.
sorry, I think there was a comment on actually we all hear the sounds comments goes from
Oh,
you.
I'm so
So
sorry.
maybe if you
Yeah,
can maybe I don't know, maybe closer to the mic or something, that'd be
sure.
great.
Actually on AirPods, but what I can do is take them off and see what happens. How's that?
Okay, perfect. Thank you.
All right. Is it a
Okay.
little easier to hear me?
Yeah, yeah.
Okay. All right, perfect. So I apologize to everybody. So in terms of what actually happens during these heat warning systems and what we can do to improve them, I would definitely recommend that folks go back and read the Kalkstein paper. This was published in the Bulletin of the American Meteorological Society back in 1996. Because an interesting takeaway from this is that it wasn't just the heat warning system. The Department of Public Health actually put in this entire host of different activities. So, for example, there were media announcements for the warning system on TV, radio, and newspapers. They came up with a buddy system where they actually encouraged community members to visit the elderly in their communities on a daily basis. They created a heat line call center, and the Department of Public Health actually did home visits to high-risk households, to nursing homes, to the homeless. There was increase in EMS staffing, cooling centers were activated, and the senior center hours were extended into the evenings and weekends. And then, as Dr. Belcamda noted before, the utility service actually was not allowed to suspend service during these time periods. So essentially, it's not just the heat warning system. You also have to, at a societal level, provide some mechanism for protection and putting these things into effect. So how do we improve the effectiveness? Well, I kind of mentioned a little bit of that, which is we have to have follow through on it, but also we have to broaden the reach of these heat health warnings. So there might be an opportunity using mobile phone or mHealth. We can perhaps improve the targeting of the messages to identify who those vulnerable populations are and reach them more effectively. One of the problems is that older adults, individuals who are vulnerable may not necessarily be aware that they are at high risk. So they may recognize the risks of high heat, but may not think that it's applicable to them. And then finally, we should be incorporating more local features. So an example would be the urban heat island effect. So what this entails is that in the inner cities, a lot of these structures are composed of metal or concrete, which really retain and hold heat. So not only is there high heat during a daytime during these extreme heat weather events, but these structures hold heat and release them at nighttime. And so oftentimes where there's relief from the heat during the nighttime, you don't get that in highly urban environments, and that can also cause significant health-related issues. So lastly, I'm just going to throw this slide up very quickly. Chandra and Lee proposed in their systematic review of these heat warning systems that we should be moving from more of a conventional static heat health warning system to what we call smart heat health warning systems. And these are some ideas behind them. The basic idea being we need to move away from temperature and humidity to really integrate individual factors and meteorologic factors, that they really need to be targeted to the highest risk populations, and they should be very dynamic and applicable to hyperlocal aspects of climate and weather as well. So with that, I'm going to pass on to Dr. Spatz. Erica, would you like me to click through your slides, or should I just have you share?
Sure, you could click through them. Thank you.
Okay.
Okay, great. Hi, everyone. Thank you so much. to all the presenters, Dr. Chang. I think this will dovetail nicely with your work, Dr. Bellamkonda, Dr. Liu, Dr. Chen. Okay, next slide. I'm going to be talking about the principles for communicating climate change. And this is really applicable to a broad range of health professionals. So I know we have a lot of different attendees today, some of whom are public health officials or students, clinicians, and those would include doctors and nurses and pharmacists. Really, we all play a role in communicating good information to our patients and to our communities. I think one of the most important things to recognize is that we are all reliable sources of information, and communicating about climate change and the effects on health are challenging. And I'm hoping that I can give you some very practical skills that you can use in your day-to-day interactions, or when a reporter calls you, and or just even amongst your family and friends. So the three important principles that I'd like for you to take home tonight, is that climate change is affecting our health today. Um, you've heard from the other presenters about the immediate cardiovascular effects that happen on a day-to-day basis with extreme weather events. And it's important to recognize that this is not an existential threat. This is impacting all of our health today. The second take home is that climate action is an opportunity to improve health and well-being. You've seen a bunch of different slides from Dr. Bellamkonda showing you what it looks like to increase walkability and have more greenery in our lives, and improve access to healthy foods so that we can avoid food deserts. These are things that climate change does impact. And when we take climate action, we can not only mitigate the effects of climate change, but also improve our total well-being. And the third message is that health professionals can be effective champions for climate solutions. And that goes back to what I was discussing before. So you've already heard about changing frequency and intensity of extreme weather, like heat waves, floods, wildfires, smoke. These are climate changes that are affecting health today. I also want to point out that vector-borne illnesses are also on the rise, and the presenters today are all from Connecticut, so we are very familiar with Lyme and babesiosis and other tick-borne illnesses, and these actually directly correlate with our weather patterns. And this spring, we are seeing a rise in tick-borne illnesses here. Um, I want to also recognize that there's distress related to extreme weather events, and that this not only includes cardiovascular health, but it also includes people's mental health, and that can affect their cardiovascular health. It can also affect our infrastructure. It can destroy property, people's homes, people's access to medications, people's ability to get to the doctor. So all of those things can impact cardiovascular health. And then again, changing food and water availability, and this really happens at a global scale. Next slide. So the World Health Organization has a really wonderful toolkit that can be very helpful for health professionals. And one of the questions is this toolkit for me? I know this slide feels a little bit blurry, but basically it starts off by saying, yes, it affects all of us, and you as a health professional can take an active role. And the other thing that it then asks is, if you already have everything you need to be effective and a powerful climate health communicator, and if you don't, we can give you the skills. Let me go to the next slide because that one's a little tough to read. Okay, so how do you communicate effectively? So first is to be mindful of your audience, and then also think about ahead of time, what is your goal? So your audience may be patients, they may be colleagues and peers. It may be your health system leadership that you're going to. It could be your local community residents, politicians and policymakers, journalists. Your messaging will likely change depending on your audience. And it's really important to think ahead of time about what is your goal. Maybe for your patient, it's to improve their health, their long-term health. Maybe it's to avoid hospitalization during some of the vulnerable months. If you're going to your community, you've heard about some of the work that happened in Philadelphia. Is it around preparedness? Is it around investing in resources, allocating funds? Is it around public health messaging? What is your goal? And let's say you're at the health system leadership. Maybe you're trying to advocate for your health system to change a vendor or change a supply chain or take action around something that is within your realm of power to influence. Next slide. So here's the tools that I want you to take home with you. Number one is to lead with health and not the environment. So if you're talking to patients, start with the symptoms of chest pain, shortness of breath, or the condition like hypertension, coronary artery disease, heart failure, as opposed to starting with changing temperatures, carbon fuels, pollution. A lot of that stuff can feel very abstract and not necessarily relevant to the individual and to their specific life circumstances. So, for example, your heart failure symptoms may be worse this season because of the extreme heat, which causes dehydration and a strain on your heart. This moves the conversation from something that's ideological to something that is important to a person's well-being, and it ends up to be less polarizing. Next slide. Number two is to make it local, timely, and relevant. And you heard a lot about this from Dr. Chang. Tie the patient's health to their current weather conditions in their living environment or where they travel. So maybe it's extreme heat, or if person's living in California, maybe it's wildfires, or maybe they're traveling to another country where the air quality is poor. Make it relevant to that person's situation. As an example, like I was talking about before, the summer in Connecticut is getting hotter each year, and we are concerned as there is a rise in heart failure hospitalizations. So it actually is something that this person might tune in a little bit better to hear what you might need to say next that affects them. Next slide. The third is to pair the problem with a solution. Don't make the problem existential. Don't cause fear or feel like there's nothing we can do about it. And that's one of the biggest challenges with climate change is that people feel like the problem is so big. How can any of the things that I do actually impact outcomes? So make it really sticky and have a solution action for that patient. So, for example, the summer is going to increase the chances of your heart failure getting worse. It's important that we do home monitoring of your blood pressure and weight. We also want to be careful about your hydration status while on diuretics. Let's make a heat safety plan, like staying indoors when temperatures rise above 90, or if the humidity goes above a certain degree, and checking your blood pressure and weight every morning. So we can give people actions that they can take to mitigate that risk. And Dr. Bellamconda showed you some nice figures about risk stratifying people based on their cardiovascular health. Next slide. So still there are barriers to communication. And in surveys, what they have shown is that frontline professionals, about half report lacking confidence in communicating about climate change. About 3/4 expressed a lack of knowledge. Many expressed time constraints, and also people felt concerns about patient receptivity to the conversation, as well as politicization. And these are real challenges, especially in today's contentious environment. And that's why really sticking with the health of the person, the timeliness and the relevance to their situation, as well as something that they can do to improve their health outcomes that relates to the climate is really important. Next slide. So here are some additional tools that you can use in your day-to-day. Number one is to incorporate a social E in your history taking. So when you're talking to your students, if you're interviewing a patient and you're interviewing them about their social history, you may want to incorporate information that will help you to understand your patient's vulnerability as it relates to environmental stressors. And these can include, do you have air conditioning? Do you have heat? Um, how do you get around? How are you getting to medical appointments in terms of transportation? What is your food environment like? Again, personalize the content. And you can do that in your after visit summaries or with educational tools in your offices by having some tips for managing the heat wave when you have heart failure, for example. Focus on health and well-being, keep it positive, okay? That's really important. In all of the materials around in these toolkits, it is really important to keep it positive. Empower people to make good decisions. A number of websites have been named today. Airnow.gov is one as well, where you can type in your local zip code and you'll get information about the local air quality. Tell stories, not statistics. So stories can also be very, very powerful, especially if you're talking to the media, and that can help more so than statistics. What to avoid? Avoid polarizing language like climate crisis, climate emergency, climate change. These verbs can be triggering and we want to try to avoid that. Also, avoid jargon. The last thing I would say, and that the literature supports, is don't debate the science. The science is not debatable. Instead, bring the conversation back to your professional expertise and the links between climate and health. You're always on safe ground to talk about what you have expertise in, what your experience has been, and make it relevant and personal for that patient. Next slide. So where does all this lead? If we're effective, over time, the goal is that people start seeing climate change as personally relevant and that people take actions to protect themselves from climate change. It would also be great if people start talking to their friends and family about climate change, and if they start talking about climate change in new and powerful ways, and especially positive ways where we can have meaningful impact. Lastly, I would say that people can help build healthier habits like eating more plants and using active transportation, things that will help them during climate changes that are impacting food supplies and such. There's a lot of other positive outcomes that can come of this. These are more high level, like joining an advocacy group or urging elected officials to deliver climate changes and such. But in the most immediate sense, just getting people to recognize the association between climate and health is a major step forward. Thank you so much. I'll turn it back to you, Dr. Chang.
Great. Thank you, Dr. Spatz. That was amazing. I apologize. I'm actually going to reshare another screen. There we go. All right. I was having trouble with the transitions, so okay. All right. Can everybody see these slides? Okay, excellent. Okay, all right. So we're going to wrap up with our third competency, which is taking us through the environmental impact of cardiovascular medicine, and we'll talk a little bit about sustainability as well. And so a little bit of a roadmap. I'll start by talking a little bit about healthcare emissions and where they are coming from. And then second, the role of the cardiovascular professional or cardiovascular healthcare provider in sustainability. And then Dr. Belcanto will bring us home at the end with a discussion about some frameworks for how to think about sustainability. So we'll start by discussing the elephant in the room, which is that the healthcare industry is a major polluter. We are responsible for 5% of all greenhouse gas emissions worldwide. And the US is actually worse because almost 9% of the carbon emissions in our country is coming from the healthcare system. And we alone, as the US healthcare sector, are responsible for 25% of global healthcare related emissions, which I suppose is not that surprising when you consider the fact that we tend to be a very interventional rather than preventive healthcare system. Now, where do healthcare emissions come from? Well, a lot of the things are pretty obvious: electricity and energy generation, transportation, things like medical devices, supplies, and pharmaceuticals. But believe it or not, anesthetic gases are a major contributor. Desflurane gas, for example, is a major greenhouse gas, independent sort of the burning of fossil fuels. And how can we think about where emissions are coming from? Well, Dr. Jody Sherman, who couldn't be with us, did want to share that many people in the audience may be familiar with the scoping language, where people talk about the three scopes of healthcare emissions. And she wanted to bring up the fact that the scoping language really is built for healthcare systems. And as a result, they're perhaps a little less applicable for individuals to think about. And that said, I still think that it's a good way to sort of conceptualize and break down the different sources. And so we won't belabor the point, but I will introduce them. So the first type of emission, they're called Scope 1 emissions in healthcare activities. And these are the obvious things. It's emissions that are directly generated from the hospital or healthcare facilities, such as things like burning natural gas for heating from the vehicles that work for the hospital and from these anesthetic gases, which I'd mentioned before. Well, Scope 2 is all the electricity that the hospital uses. And then finally, Scope 3, which is the largest by far, is the supply chain. And that includes all of the emissions that come from producing all the pharmaceuticals, the medical devices, the food, and waste management. And to understand exactly how much of a contributor each of these sections is, we'll start with a little bit of a pie chart. So Scope 1, these are the direct emissions from healthcare operations. It's only about 7%. And then Scope 2, the electricity needs for the hospital and healthcare facility, only about 11%. And so Scope 3, the supply chain, ends up being about 80%. And something I did want to mention is that while healthcare systems do exert direct control over Scope 1 and 2 emissions, they can only influence, not control Scope 3 emissions. And that's not to imply that we're passive in Scope 3 emissions, because we certainly can do things like lobbying for more efficient or energy conscious suppliers. But either way, the point is that these are more indirect mechanisms that we have to use to influence the largest contributor of emissions. So bringing it back to cardiovascular medicine specifically, we're a particularly carbon intensive healthcare practice. And part of that is, as I mentioned before, we're a highly procedural specialty. First, more than 1 million cath procedures are done in the United States, and cath lab activities use a lot of single-use products. Catheters, drapes, gowns are taken down after the procedure and never used again. And we also have a lot of high energy demand activities. For example, fluoroscopy, the use of anesthesia for our procedures. Also, cardiovascular diagnostic testing isn't really so cardiovascular. Actually, echocardiograms, for example, are more prescribed by non-cardiologists than cardiologists in the United States. And to that end, there's at least 20 million echoes that are performed every year in the United States alone. And stress testing, things like CCTA, well, I guess it's technically coronary imaging rather than stress testing, but the point still stands that nuclear perfusion and stress echoes are routinely ordered by non-cardiologists, both for symptom workup as well as for things like preoperative risk stratification. And so we have an outsized impact on healthcare emissions, not just within the scope of our own practice. So what's a cardiologist to do? Well, primum non nocere is first, do no harm, which is one of our Hippocratic edicts. And it may seem that the very act of delivering healthcare may come at odds and sort of creates a catch-22 of sorts, because one way of thinking about it is that when we take care of our patients, we generate carbon, and that ultimately causes environmental issues which turn around and hurt our patients again. And so what are we to do? Well, Dr. Sherman published an article called Net Zero Healthcare in the BMJ in 2021. And I really, really like this quote that she shares in it. And I'll read it. And it goes, planetary healthcare requires embracing an expanded notion of the principle, first, do no harm, beyond care for individual patients to a duty to protect the Earth's natural systems on which intergenerational health and well-being depend. And my interpretation of this is that good planetary stewardship is good patient care, and good patient care ultimately is good planetary care. And a pictorial way of thinking about this is that we, as cardiovascular and healthcare providers, can partake in direct actions that can reduce pollution as well as carbon generating processes, but also by adopting a planetary health framework, we can pursue activities that are win-win situations for both the planet as well as our patients. And as we know, they impact each other as well. So to dive a little bit deeper into this article by Dr. Sherman, Net Zero Healthcare, a call for clinician action. And I definitely recommend that everyone on the Zoom call go ahead and read that. It's a pretty quick read. It was published in the BMJ back in 2021. And in it, Dr. Sherman explains 3 mechanisms that the clinician can use to improve the sustainability of healthcare. And so the first is to reduce emissions from healthcare services. These are more obvious. And the second is to match supply and demand for healthcare. And what that means is that we try to make sure that we're providing appropriate care and avoiding any unnecessary tests or treatments, because unnecessary treatments are bad for the planet and are wasteful. And finally, the third is to reduce the demand for healthcare. And what we mean by that is that by investing in prevention, whether that's primary, secondary, or primordial, that we can really circumvent more intensive downstream health resource use from advanced disease, which could have been prevented before. And Dr. Sherman also frames these 3 actions within levels. So the levels include individual health professionals, individuals working together within a healthcare organization or within communities, or finally, interactions of individuals and these collectives in our professional societies with each other, as well as regulatory and oversight bodies. So in the remaining time that I have, I'm going to try focus mostly on individual health professionals because that's sort of the audience that we have tonight. But if there's a little bit of extra time, we'll see if we can quickly breeze through health organizations and professional societies. So point number 1, reducing these emissions from healthcare services. An example would be investing in telemedicine and video visits. So this is a little bit of a no-brainer, but by consider using telehealth for simple visits like result communications and stable follow-up, we can reduce patient travel and thus the carbon footprint of their travel and potentially ours as well too, and anything that's generated from the use of clinic resources. And an example that's pertinent to cardiovascular medicine is using remote transmission for routine pacemaker monitoring rather than in-person visits. Also, by using multidisciplinary consultations and diagnostic testing within a coordinated care visit, we can actually see if we can take care of the patient and consolidate their care within one visit. And doing that would allow us to reduce the need for travel, not just for the patients, but also clinicians. There's reduced clinicians, as we discussed, and also we can take better care of our patients because providers can discuss sort of at the point of care with each other. And an example in cardiovascular medicine that we use is these multidisciplinary structural heart clinics where a patient can come in, they can get their echocardiogram, they can then see an interventional cardiologist, and then finally they can see a cardiothoracic surgeon. And in this one extended visit, they're able to get it all taken care of. It's better patient care, and it also reduces our carbon footprint of this practice as well. Also, the big one, which is reducing supply chain emissions. One of the big things that we can do is choosing reusable products instead of single-use devices, or advocating or working to develop reusable products. And one of those examples that's very common in the cath lab is avoiding custom packed procedure kits. I know anyone who's a fellow here going through their interventional cardiology rotation can remember rooting through a large pre-prepared kit just to find a single catheter they're going to use and throwing away the rest of it. So by planning ahead and choosing tailored supplies rather than pre-packed kits, we can really avoid waste when there's going to be equipment in them there that we know we're never going to use. Another thing we can do is lean into using digital tools in the EHR where possible and avoiding printed paper. An example of something we're piloting in our Echo Lab is to use a digital continuous ECG trace during stress testing rather than having it continuously printed. And I mentioned this before, but trying to find alternatives, let's say, propofol or IV medications for anesthetics instead of desflurane anesthetic gases for procedures, because a single hour of desflurane use can actually have the carbon footprint that's equivalent to driving over 400 miles because it is such a potent greenhouse gas. And lastly, we can really optimize our diagnostic testing. Where there is equipoise in what type of diagnostic test we can choose, we should be choosing the most environmentally friendly option. And to give a cardiovascular example here, you can consider using a stress echocardiogram and ordering that instead of a coronary CT or a nuclear stress test for workup of coronary artery disease, assuming that there's nothing else you're looking for that would necessitate the use of those tests. And Dr. Bellicondo will talk about that a little bit more in our closing section. But I did want to make mention of the LCA or life cycle analysis, one of the very few that's actually in the field of cardiology that was published by Marwick and Buonocore that compared echocardiography, SPECT, which is nuclear stress testing, and cardiac MRI, and basically found that relative to echocardiography, SPECT exacts 7 times the fossil fuel burden, while MRI incurs a staggering 69 times the fossil fuel usage. So if these things are all in general equivalent, we should be trying to prioritize the more environmentally friendly option. In terms of the second point, which is matching supply and demand for healthcare, we should be really avoiding any unnecessary treatments and investigations. And this seems like a little bit of a no-brainer, but unfortunately, there's a lot of practices that are unconsciously occurring. So, for example, defensive medicine, oftentimes we end up ordering tests and treatments, well, that are low value and have a low likelihood of really meaningfully changing the patient's outcome, but we do mostly because we're worried about the consequences of not doing them. So by reducing those types of drivers, we may be able to reduce unnecessary tests. And part of that also involves provider education. We can also avoid duplicated tests. Everybody knows here, you may order a lipid panel on a patient and then turn around and find out that the primary care doctor did the same. So by coordinating care between providers, we can reduce that as well. And then finally, incorporating patient preferences. Oftentimes we order things without taking into account patient preferences. And when we ultimately talk to them, we'll realize that their goals are not aligned with our goals. And perhaps if it's not going to make a difference in terms of their outcomes or their disease course, that perhaps a superior alternative may not be to do the testing or the treatment at all. And then finally, ensuring appropriate care. So reducing healthcare disparities and investing in primary care, as I mentioned before, at lower acuity disease states avoids more costly downstream care. And then the third point, which is reducing demand for healthcare. Another quote, this is from Dr. Sadir Al-Kindi and Dr. Sanjay Rajagopalan, and they published in the European Heart Journal. And I really like this quote of theirs, which is that as a field, we need to reimagine cardiovascular prevention as a core pillar for environmental sustainability. And this is very important because we really spend an exceptional amount of our services on a very small population with very advanced chronic diseases. And so again, I cannot emphasize on this enough, but good prevention is ultimately good for the planet. And then we should also be using evidence-based non-pharmacologic or lifestyle approaches. These are things that we can consider using in addition. So, for example, dietary improvements like plant-forward diets, community gardening, exercise, particularly things like walking groups that have benefits not just for exercise, but also mental health, substance cessation, and integrative medicine for symptom management, things like acupuncture, meditation, massage, and mind-body practices. And last but not least, nature and green space exposure. It turns out that there's benefits to being out in nature and in green space. There's this concept in Japan called forest bathing, and there appears to be some science behind that, as well as perhaps trees secrete volatile organic compounds that may actually be beneficial for our cardiac health, may lower blood pressure. And so, where possible, using non-pharmacologic, non-procedural, and lifestyle approaches may be helpful. And then very quickly, I'll kind of touch on some of the organizational, community, and professional society level interventions. So the National Academy of Medicine published this document called the Key Actions for Health Professionals to Advance Sustainable Healthcare. And I will focus a little bit on the health system level actions. But in general, the goal is for individuals within these organizations to participate, lead, or create institutional level initiatives to reduce waste and emissions. And these would be things like promoting device reprocessing, working sustainability into the procurement process, and promoting employee-based commute-related emissions reduction initiatives that we've all seen before. Again, on that point of sustainable procurement, because we know that the supply chain is the single largest source of emissions, by prioritizing vendors who prioritize sustainability efforts or asking them to increase their transparency in this regard, we can really influence them to do right by the planet. And then finally, education, as Dr. Spatz implied, it's not just our patients and our peers, but also the general public. And then finally, as many of us are in academic scenarios or responsible for training others, by teaching trainees about these topics of climate, health, and healthcare, can allow them to integrate this into their activities and hopefully into the usual clinical curriculum for students of all levels. And then lastly, advocating for our administrators to include climate resilience plans into our hospital and clinic workflows, with special attention, of course, paid to serving patient populations who are vulnerable and at disproportionate risk of climate-related harms. All right, so I am done with this section. If anyone has any questions on this, feel free to email me at this address. And I will turn it over now to Dr. Belacomda to wrap up. Lavi, would you like me to click through the slides?
That would be great since you have it over there.
Okay.
Thank you.
All right, give me 1 second. I'm going to.
Don't worry, if you're looking, I'll just look up. I have it right here.
Oh, you do? Okay.
Yeah. So just to bring this all home, how can we incorporate the dual goals of helping the planet while we help our patients? And I think this starts with looking at climate change and interventions to prevent climate change as a continuum of healthcare that we provide to our patients, rather than looking at them as two diametrically opposite goals. And in that line, both Dr. Spatz and Dr. Chang have suggested incorporating low carbon habits that are good for the planet, which are also good for health. We talked about active transportation, encouraging patients to walk, to bike to their commute, would reduce the carbon footprint, but also improve their cardiovascular health. We know this very well. Also know that plant-forward diets, like Dr. Chang already mentioned, not only reduce the emissions, but also reduce cholesterol levels and reduce the risk of atherosclerosis, risk of having having a heart attack, and can be good for the planet as well. Now, this is a very interesting concept, and one of Dr. Chang's favorite, I will say, which is considering what is called the triple bottom line. Interestingly, triple bottom line was first introduced by John Elkington back in the 1990s, and he was pitching this as a framework for sustainability for organizations. And what he suggested was 3 Ps: profit, people, and planet. And he suggested incorporating all these 3 while making decisions for organizations and industry. And this was later adopted by Gunashekhar and colleagues when they, in this paper where they talk about doing the same, incorporating environmental aspects along with the social and financial aspects of it, in cardiovascular imaging, like Andy suggested earlier. So we do this partly when we look at our patients and we're trying to order an imaging study. We look at the cost effectiveness analysis when we're looking at the utility of a given study, but then also including the carbon footprint from that investigation in that imaging would help you look at it in a more holistic manner while we make these decisions to take care of our patients. And this can be expanded not just from imaging, but to our day-to-day care of our patients in every aspect of care. With that, I will hand this back to Dr. Kai Chen.
Thank you, Ravi. Thank you, everyone. I think this is a truly amazing dialogue, and we hear different aspects from the definition of climate change, epidemiological evidence, to what are the type of interventions for patients, for the public, but also from the healthcare perspective, the emissions, and how to best incorporate these considerations in the daily activities, in the communication with patients. And also at the healthcare as a whole, what we can do. So I think we now comes to the Q&A phase, and there's at least for now there's 3 questions. We can answer them one by one. In the meantime, for audience, please feel free to type your question in the Q&A. The first question is, I believe this was happening during Andy's talk. Was talking about how can they be sure the lives were saved by these advisory warnings. Do they send surveys?
Sure, happy to take this one. And so some people may have noticed I didn't include in my slides some of the more, I guess, splashy studies. I think there's one from France that made some claim about 3,000 plus lives being saved by the heat warning systems after the big Paris heat waves in 2003. And it's a really good question. We could spend forever talking about the methodology behind it, because you're right, it's very challenging, right? How do we actually ascribe causality specifically to these interventions? The long story short, I think Dr. Liu did such a great job. I love that one slide that she had, where we sort of discuss how do we model, right? A lot of it involves modeling the expected number of mortalities should things not have been changed. And then we looked at what was observed, and oftentimes the delta between that can be ascribed to that event, or you can actually model the actual heat warning itself can be modeled as well too, and seeing, and that's what the folks in Hong Kong did. In terms of the German analysis, or in South Korea, they actually used a difference in differences approach, which is more of a natural experiment. And so what they would do, again, don't want to spend too much time talking about methodology, but you can actually look at conditions that are very, very similar, where only one thing is different. And the goal is to use that to see what the effect of that is. And to give you an example, there is no huge physiologic difference, right, between, let's say, 99.9 degrees Fahrenheit and 100 degrees, right? But let's say that a heat warning is triggered at 100 degrees Fahrenheit, right? So by looking at that, this is, I guess, a little bit more of a discontinuity, but the point is we can leverage these, these natural experiments that occur. And so hopefully the idea is that, there is an assumption that that is the one major change, but, we can look at that. So those are some big picture explanations for how we look into see the efficacy of these heat advisories and warnings.
Wonderful. Thank you. So the next question from Barry Zizer is basically asking a question by, climate change itself become politicized, but even if we don't mention climate change, perhaps simply focusing on air pollution's large burden from fossil fuel, land, water degradation, and also the current annual subsidies to the fossil fuel burning and the low cost of renewables, etc. Um, you know, as well as current related cost of wars due to fossil fuels, along with their economic disruption. Wouldn't the exact same remedies that would address climate change still have the same compelling and urgent support? So I think this is a perfect point, because what we are trying to say is that a lot of the cardiovascular risks or threats we're seeing is not purely driven by climate change itself. Most often climate change is a multiplier, so it's kind of exacerbating the existing risks that we see. So in a way, what we talk about the health effects is through weather events. If we would just look at what has been occurring, these are the facts, right? For Annie mentioned, you have different methodology, causal inference approach to kind of basically attribute how much in the past mortality, morbidity burden due to different temperature, air pollution, water smoke, etc. But that is already occurring, so we are already seeing these impacts. Um, I think that is loud and clear, and to the methodology we mentioned to address them. Some of them, like if you recall, the two big categories. One is mitigated emissions. These are mitigated emissions, the root causes for the future that really, when we think about the next decades to by the 2100, these are the changes that we can make. But then at the same time, a lot of measures that we actually measure for the intervention measures, these are the reduced vulnerability to the health effects of for climate change. So these are the things that exactly, even if we do not mention the climate change term, these are things that we should still put it forward. As a matter of fact, and NIH has the program now called Health and Effect and Health and Extreme Weather Program that has been ongoing, and I think similarly, the argument is no, no, despite the argument or the potential debate, the things we need to do remain the same. But of course, sometimes if you don't acknowledge the root cause, sometimes in the federal level, the national policy cannot be moved forward. But luckily, I think we do see, as you mentioned, from the economy perspective or from a health perspective, local, regional governments and even the industry, because yes, indeed, the green energy is much cheaper now. So there's not much incentive for the industry to go heavily on this. So I think that the whole trend is moving towards that direction. That's why I personally have a hope. So I think just opening to any other reflections on this. If no, then we can maybe move to the next question. Again, for Dr. Chang, thank you for cool presentation. I think this is related to the urban structure trap and really release heat at night, removing that a Euro overnight recovery, that Euro overnight recovery. Do current heat emergency thresholds even account for that? Or are cities still using daytime temperature cutoffs that makes the urban nighttime risks?
Sure, that's a great question. So as you probably saw at the level of National Weather Service alerts, the geographic regions are too big to incorporate cities, and so the answer is probably not at that level. Now, in terms of more local heat alerts, sort of at the municipal level, there's a few different ways to get around it. Um, so the short answer is that they don't, but the long answer is that they can kind of indirectly get at it. So people have wondered whether it makes sense rather than doing the peak temperature to look at mean temperature, which can kind of take into account nighttime temperatures. And some jurisdictions will actually use minimum temperature. Which actually, I think, in many ways reflects the nighttime heat trapping effect as well too. So a little bit of a longish answer to basically say not directly, and certainly not at larger levels. And so you can imagine the heterogeneity, right? You could say, oh, Oklahoma is under heat alert based on a National Weather Service alert, but Tulsa is going to be very different from, out in the countryside. But at the city level, by using minimum temperatures, you could potentially capture that.
Yeah, just adding to that, I think there's emerging evidence, regarding, specific focus on nighttime heat, right? Because, nighttime heat, one of the things that the people worry about is nighttime heat disrupt the sleep, and the sleep disruption leads to a lot of, stress and to mental stress, but also leading to cardiovascular risks. We do see some of our own studies, for example, in Puerto Rico, hot night access can lead to additional risk. Even in addition, you control the daytime temperature. And there are other studies in California showing that if you define heat wave, not compare with if you define heat wave using daytime temperature, nighttime temperature defined heat wave can be more risky in terms of mortality and morbidity burden. So I do think that people, more and more evidence showing up, and think that may have more kind of clinical but also public health implications. So let me go to the next questions is, what are the climate-related cardiovascular trend do you believe we are generally underestimating? And what can we realistically implement to reduce its long-term impact? I think I'm open to all because, this is a really nice question because we only know what we know. But I think, especially for my colleagues in the School of Medicine, you have a better sense of that. When we do epidemiology, just to look at data, I guess you have more kind of hint on what could be. So I'll just, open the floor for everyone to chime in.
That's a very important question, and I think Andy and I were talking about this the other day. One of the main issues, and I'll take it from the coding angle, and I'll let my colleagues jump in from other aspects of that question. There's no real ICD code, right? We measure disease, we measure the impact of a condition based off of collecting data, and we are not really collecting data on this particular condition because there is no ICD code for climate change or climate-related cardiovascular impact, such as we don't collect data specifically, and we don't code it as wildfire-associated heart attack, or we don't say temperature-associated cardiovascular disease. Although we do talk about heat strokes, there is no ICD code for heat-related heart failure or myocardial infarction. So we don't have a good way to measure all of these conditions that we just discussed, as we're not recording them on a population level. That's one aspect of it. But then going through each one of the components of climate change, for instance, extreme weather event, when there is a hurricane, we know that the events go up. We know that the events of MIs go up. But we're not capturing the whole spectrum of it. There's a lot of displacement happening. Which location and which geographical area are we measuring the increased events? And how do we track these people? These are all many aspects of the challenges that we face when we are trying to attribute risk and with any of these conditions. Similarly with air pollution, where do we measure air pollution? What devices are we looking at? The national level reports? Are we looking at the at the local air pollution measurements. They're all different, and then there are portable measurements that you can get with on an individual level to assess exposure to air pollution. So these are all aspects that need to be considered, and this needs to be an epidemiological collaboration to pin down. Unlike other risk factors like diabetes or hypertension, which are individual patient level risk factors, this exposure risk is hard to gather.
And I also just want to add something like I think we are probably also underestimating long-term cardiovascular impact of repeated low or moderate climate exposure, not just the dramatic heat wave, wildfire, or flood, but many patients they are repeatedly exposure to days of higher than usual like air pollution. Actually, in a recent study, I collaborated with Kai. We look at low level of PM 2.5, which is the level that lower than what the EPA standard. But when we look at long-term exposure, we find that even the low level of PM 2.5, the cumulative exposure can increase the risk of hypertension, hospitalization. So each episode may look small, but over years, the long-term cumulative burden may actually accelerate like heart failure, stroke, hypertension, or other cardiovascular vulnerability. In terms of what we can realistically implement, I think one promising way is to look at the risk-based climate prediction model in cardiovascular care. Maybe that can help health system to identify high-risk patient, like older adult patient already have existing heart disease, like heart failure, prior MI or stroke. We may use like EHR-based alert or patient portal text messaging can provide targeted guidance before these heat or smoke event happen. So in general, I think we can move from more public warning to more clinical targeted prevention, use some of the tools that are already available in the health system to protect patients that most likely to be harmed. That's just my 2 cents.
Yeah, I'd love to follow up on that point, which is related to prevention and understanding a person's risk over their lifespan. And we know that cumulative exposure impacts cardiovascular health. And so it's not just the zip code where somebody lives right now, but where they grew up can have a really big impact. So thinking about, where was that person born and where were they raised? What were coal burning practices? Um, uh, Exposure to vehicular emissions, um, ppm, that all kind of can create cumulative cardiovascular risk, and we can see more premature coronary artery disease and heart failure that relates to prior exposures. And then the second thing I'd like to also see us pay more attention to goes back to the social determinants of health and the built environment. We know that there's a lot of heterogeneity of risk within our cities related to whether or not there's a lot of greenery or the temperature within a city can vary by more than 10 degrees on any one given day, depending on where you're living. And those differences in temperature are compounded by less access to air conditioning and transportation and ability to get out of the house and get medication. So really understanding the vulnerability of our patients is another aspect that I'd love to see us pay more attention to.
Great, thanks. Annie, do you have anything to add?
I want to be mindful of the time because I know we got one more thing to add, but not to throw even more complexity into this. But like Dr. Liu had mentioned, we also are just scratching the surface of the combination of these. And for anyone who's gone through a master's program in epidemiology, if you've ever drawn a directed acyclic graph or a DAG, now imagine these myriad low-level environmental impacts, all of which are being driven by climate change, their intersection as well too. So we're really only scratching the surface of all this.
Yeah, well said. Sometimes we also will see that the link between climate and health is really what we call a causal web. And what we know right now is really just a single link, and only a few of them are well studied. We don't have much evidence. That's actually why we need our audience to join the fight together, through research, through education, and through communicating with your peers. And that's why we want to do this today. Okay, let's move on. We have 4 minutes left. Quickly, next question is, assuming the worst case scenario, what do climate models show? And does temperature eventually can actually plateau after, no matter how long the rising phase will be? Unfortunately, all the global climate models in model by the end of 2100, because the further you go, the less relevant for policy. And also because if you recall in my figure shows, different scenario, like high emission scenario, low emission scenario. Unfortunately, by 2100, the global, at least, by the middle or late of this century, the temperature is going to keep going up, no matter what we do. Even if, let's say today, we achieve zero carbon emission, because there's a lagging period from the carbon emission emitted and it's warming. And recall that the ocean warms later, warms slower, but also means it absorbs a huge amount of energy. So that energy also, goes out. So it kind of that's the reason why even today we achieve zero emission, we will still have an increasing warming temperature. So I think that is unfortunately the reality we're living in. But what we can control is how worse it can get, right? So I think that is the in terms of mitigation perspective. Um, Okay, and then last question, I think this is in regards to Dr. Liu's discussion of flooding and mortality. I really appreciate this because I feel flooding is under discussed in this regard. Has mold exposure been looked at as an indirect pathway from flooding to cardiovascular mortality? Is there any other research on how it affects cardiovascular health directly?
Luke, if you want
Yeah,
to take that. Yeah.
yeah, I think that's a very important question. I agree, like flooding is probably under discussed in cardiovascular medicine. Um, Many of the flooding literature traditionally focus on injury, infectious disease. There's a growing recognition that flooding can also affect cardiovascular health through different indirect pathway, like maybe stress, interruption of healthcare access, medication disruption. Um, I I think the mold exposure itself may have been studied more extensively in the respiratory disease and allergy condition. Um, Maybe I'm not like an expert in that domain. There may be emerging evidence suggests a possible cardiovascular effect as well. So I don't know, Kai, if you have more deep knowledge in terms of the mold exposure. Um,
Uh,
I think one of the challenge for mold exposure is difficult to measure accurately at a large scale. And it may be also coexisting with other stressors after flooding, like housing instability, some of the socioeconomic determinants, economic stress, etc. So, but I do think it's an important future research direction. Kai, do you have any more things to add?
Yeah, I think this is an excellent question. That's why we are doing the study, looking at long-term flooding exposure and cardiovascular hospitalization. And we do, in the study, we show that, in the US, long-term flooding every year, more than 1,000 deaths can be attributed to that. That's a long-term flooding. And most of that we suspect is through indirectly, not directly. And I think this is just the beginning. We see some multi-country studies in low and middle income countries in flooding and its cause-specific hospitalization, including cardiovascular disease. I think the epidemiological studies are just, beginning, and accompanying that is a better understanding about the mechanisms, right? So, like, I think, Andy and Lavi mentioned some of the things that during for example, hurricanes. If you think about that, the supply chain disruption, that's a healthcare disruption. How much impacts it goes through that? These are the things, the open questions for us to answer.
There's a
Uh,
couple of studies based off of not so much flooding directly with small storms, but from Hurricane Katrina and Sandy, the two big ones that we had. And the data from Tulane after Hurricane Katrina was the number of MIs doubled within 1 year after the hurricane. But all of these were attributable to indirect causes, like Dr. Liu was suggesting. There was no direct impact other than loss of insurance, loss of healthcare access, loss of medications, and psychiatric illnesses, and substance abuse. But there is no direct pathophysiological mechanism that was described in those two papers. But we'll see what Dr. Chen has to offer with the ongoing studies on flooding.
Yeah, thanks, Levy. I think it ties with the very last question. Also, in a minor time, we only have we're already exceeding 9 p.m. So let's just quick answer the last question. What more research we need? I think that's exactly, if you listen to every section, that's epidemiological evidence why, like you here mentioned, there's a lot of air pollution heat, not much on the extreme weather events like Wi-Fi smoke. We're just beginning to understanding. Flooding, we don't know much. Hurricane, what are the long-term impacts? The studies showing, the hurricane impact can even have a decades-long impacts on the, mortality and morbidity, right? So all these things are under studied. And the matter of fact, US, we have the billion-dollar disaster event. That billion-dollar disaster is only counting about the physical damages and economic costs. No health cost was encountered. So you can see there's huge underestimation about the health impact, the cardiovascular health impact there. So I think there's a lot, huge opportunities for us to do. And as I mentioned earlier, climate change, the impacts the causal web is they interact and intertwine, compound with each other. We're barely to understand each single link, right? So I think there's huge opportunity for us to actually do more research on this. With that, I want to maybe pass to each of our panelists to see their final thinking on this. Maybe again, starting from you. Yeah.
I
Yeah, I
think this has
think
been a great discussion. I would just thank everyone who attended tonight. It's just inspiring to see so many people come to this event. This is our first one, and I think the questions that you've asked are really thoughtful, and I'm inspired to continue doing this work, and I look forward to connecting with others after. Thank you.
Yeah.
Yeah, thank you everyone for joining us today. I think one of the key message from today's seminar is climate change is no longer a distant environmental issue. It's become part of the everyday cardiovascular care and public health practice. And thank you so much for your attention. We look forward to continue this conversation and collaborations in the future.
Lawi?
I think this was a great discussion from different perspectives, and I think this is how we have to address the problem as well, by collaborating with colleagues across the spectrum to get to real solution for this problem. Thank you.
Andy?
Sure. My thoughts are that I think a lot of our energy, and rightfully so, has sort of been spent trying to understand the impacts that these climate manifestations have on cardiovascular health and on human health. But I think I really liked Erica's point that the science is not debatable. Climate change is absolutely real, right? And so understanding is obviously a key part of the equation, but we do really need to focus on these mitigation and adaptation strategies moving forward. And it's not we're not passive actors in all this. That these things can be devised, the same kind of energy that we've used to solve major issues in human crises. The COVID pandemic, smallpox, removal of lead from sources. All these things that seemed insurmountable at times. Ultimately with human ingenuity could be fixed. And so I think the exciting thing is the next phase is mitigation and adaptation.
All right, since we're already 5 minutes past, I want to thank everyone, thank all our panelists for the nice presentation, and thank you all for joining. Please, we will send out a follow-up email, do a very quick, short time survey. If you can spare us 1 to 3 minutes to tell us what you learned, what things you expect us to provide more, and help us improve. And we will look forward to opportunities to maybe have a different format of continue this conversation, either in maybe perhaps a short-term course or maybe in a dedicated session discussion in our incoming Yale Forum on Climate Change and Health. So thank you all for joining us, and we're looking forward to see you again. Take care.
Thanks, everyone.